There's a reason neuropathy often progresses long before diabetes is formally diagnosed. And it begins with a misunderstanding. Insulin resistance is commonly framed as a blood sugar problem. Now, that framing is incomplete. Insulin resistance is a signaling disorder. Glucose is downstream and insulin signaling is upstream. When signaling efficiency declines, tissue behavior changes long before glucose crosses any diagnostic thresholds. So, diabetes is a late-stage label. Insulin resistance can exist for years before that label appears. And nerve tissue does not wait for labels. It responds to conditions. To understand why insulin resistance matters in neuropathy, first we have to understand what insulin actually does. Insulin is not simply a glucose transport hormone. It is a regulatory hormone that coordinates energy distribution and cellular behavior. It influences things across the entire body, like cellular glucose uptake, mitochondrial activity, nitric oxide production, lipid metabolism, protein synthesis, inflammatory tone, and autonomic balance. It helps determine how tissues receive fuel, how they produce energy, and how they respond to stress. When tissues become resistant to insulin, compensation begins. The pancreas produces more insulin. Blood glucose may remain within normal range. A1C may still remain acceptable and normal, but signaling efficiency is already declining. Hyperinsulinemia becomes the bridge that maintains normal glucose while instability builds underneath. This compensation can persist for years. During that time, several processes begin to shift. Endothelial nitric oxide production weakens, oxidative stress increases, inflammatory signaling rises, lipid metabolism becomes distorted, and free fatty acids circulate at higher levels. When this happens, mitochondrial efficiency declines. Now, these changes, they're gradual. They're not dramatic. They rarely produce immediate symptoms. But nerve tissue is metabolically demanding. It requires continuous ATP production. It requires stable substrate delivery. It requires reliable microvascular perfusion. It does not tolerate volatility very well. So when insulin signaling weakens, the environment surrounding nerve tissue becomes less predictable, and unpredictability is destabilizing. So first, let's examine the vascular dimension. Under normal physiology, insulin stimulates endothelial nitric oxide synthase. Nitric oxide promotes vasodilation. Vasodilation improves capillary level blood flow. Nerves are supplied primarily at the microvascular level, not large arteries. So macrovascular imaging can appear normal. Peripheral pulses can be intact. But capillary perfusion can become inconsistent. Insulin resistance impairs nitric oxide signaling. Endothelial cells shift towards vasoconstrictive behavior. Microvascular dilation becomes less reliable, so oxygen delivery becomes inconsistent. Nutrient delivery becomes inconsistent. Repair efficiency begins to decline. Now, it doesn't decline catastrophically, but cumulatively. Now, The next one we should talk about is mitochondrial function. Insulin influences mitochondrial biogenesis and substrate utilization. When insulin resistance develops, cells shift towards metabolic inflexibility. They become less efficient at switching between fuel sources. Electron transport chain stress begins to increase, and reactive oxygen species production rises. Antioxidant defenses become strained. Mitochondria generate ATP, and ATP is what powers nerve conduction. When ATP production becomes inconsistent, membrane potentials destabilize. Ion gradients fluctuate. And small fiber nerves, which are thinly myelinated or unmyelinated, become especially vulnerable. They rely heavily on oxidative metabolism. They lack structural redundancy. Those are the nerves that are often the first to express dysfunction. This is why burning, temperature sensitivity, and dysesthesia frequently precede numbness. Large fibers tend to decline later, and small fibers strain first. Now, let's talk about inflammation. Insulin resistance promotes low-grade chronic inflammation. Adipose tissue becomes metabolically active. Cytokines like TNF alpha and IL-6 increase, so oxidative burden rises. Chronic inflammatory signaling lowers nerve tolerance. It alters ion channel behavior. It sensitizes nociceptive pathways. It interferes with axonal transport. And it impairs regenerative signaling. Again, it doesn't happen right away, but gradually. Insulin resistance is not a single pathway failure. It is a systems shift. And neuropathy often reflects system stress before it reflects structural collapse. So let's introduce a timeline. Phase 1, insulin resistance begins to develop. Fasting insulin rises, glucose remains normal, endothelial signaling begins to weaken. Mitochondrial stress increases, so no diagnosis is made. Then phase 2, glucose variability increases, triglycerides rise, HDL decreases, inflammatory tone increases, and small fiber symptoms begin intermittently. Now you feel burning, tingling, increased sensitivity, and symptoms begin to fluctuate. Then phase 3, prediabetes or diabetes is diagnosed. Microvascular strain is established. Small fiber dysfunction becomes persistent. Large fiber decline begins. The repair capacity is now going to be reduced. By the time diabetes is labeled, neuropathy may have already been active. Now, this is not speculation. Small fiber neuropathy has been documented in individuals with prediabetes and impaired glucose tolerance. The nervous system often feels metabolic instability earlier than other tissues. Now, let's address a common objection. Is insulin resistance responsible for all neuropathy? No, of course not. Autoimmune neuropathy exists, toxic neuropathy exists, some may have genetic neuropathies or mechanical compression. A lot of different reasons why neuropathy can exist, but when metabolic instability is present, it becomes a limiting variable. Limiting variables cap your recovery. If insulin resistance persists, mitochondrial efficiency remains compromised. If mitochondrial efficiency remains compromised, ATP production remains unstable. If ATP production remains unstable, nerve repair remains constrained. This is systems logic, not metabolic absolutism. Now, consider a clinical scenario. A patient presents with an A1C of 5.9, normal fasting glucose, elevated fasting insulin, rising triglycerides, burning in the feet at night. On paper, according to the labs, nothing is alarming, but physiologically, signaling strain is active. Insulin resistance does not require overt hyperglycemia. It is a spectrum disorder. Another scenario. A patient reduces A1C from 8.1 to 6.7. They improve diet. They lose weight. But neuropathy symptoms persist. Now, why do you think that is? Because improving exposure does not automatically restore signaling efficiency. Nitric oxide production may still be impaired. Microvascular remodeling may still be incomplete. And mitochondrial density may still be reduced. Inflammatory tone may still be elevated. Lowering glucose reduces one stressor. It does not instantly remove all constraints. Now, let's consider lipid metabolism. Insulin resistance alters hepatic lipid handling. Triglycerides increase, free fatty acids rise. Free fatty acids impair endothelial function. They worsen nitric oxide availability. They increase oxidative stress inside peripheral nerves. This compounds mitochondrial strain. Now, let's discuss metabolic inflexibility. Healthy tissue can switch between glucose and fatty acids efficiently. Insulin resistance reduces this flexibility. Cells become inefficient at substrate switching. Energy productions become rigid. Rigid systems are fragile under stress. Fragility expresses as symptom fatality. When fuel delivery is inconsistent, nerve output becomes inconsistent. That inconsistency feels like fluctuating pain, unpredictable numbness, variable balance, not random, biochemical. Now, let's talk about repair. Nerve repair requires adequate oxygen delivery, stable ATP production, controlled inflammatory signaling, functional Schwann cell support, efficient axonal transport. Insulin resistance compromises each of these. You can reduce pain perception, you can dampen symptoms, but regenerative capacity remains limited if the metabolic environment remains unstable. This explains plateau patterns. Initial improvement, then stagnation, because the limiting variable was never removed. Now, we have to speak responsibly. Not all nerve damage is reversible. If axonal loss has progressed beyond a threshold, full regeneration may not occur. Structural damage has biological limits, but metabolic instability can worsen almost every neuropathy phenotype. Reducing instability raises the ceiling of potential recovery. It changes trajectories. Not because it guarantees reversal, but Because it removes friction. Insulin resistance is underestimated in neuropathy, not because it is dramatic, because it is gradual. It reshapes signaling quietly. It alters microvascular tone slowly. It increases oxidative burden incrementally. It changes the conditions under which nerves must operate. Neuropathy is often described as nerve damage. In early stages, it is frequently nerve stress. Stress is environmentally mediated. Change the environment, change the trajectory. So the better question is not, is my glucose normal? The better question is my metabolic signaling stable? Is insulin sensitivity improving? Is microvascular reliability improving? Is inflammatory tone decreasing? Is mitochondrial output more predictable? These questions reflect systems thinking. Systems thinking governs outcomes more reliably than isolated metrics. When insulin sensitivity improves, nitric oxide signaling will also improve. Capillary perfusion stabilizes. Oxidative stress decreases, and mitochondrial efficiency improves. ATP production stabilizes. Energy becomes predictable. Predictable energy supports predictable nerve signaling. Predictability is often the first sign of improvement, not silence, predictability. Fewer unpredictable flares, shorter spikes, more consistent days. That is meaningful progress. Insulin resistance is one of the most common constraints in neuropathy progression. When unrecognized, it becomes a ceiling. When addressed intelligently, it becomes a leverage point. Neuropathy is not governed by glucose averages alone. It is governed by metabolic stability across vascular, inflammatory, and mitochondrial domains. Stability cannot be reduced to a single lab value. It is reflected in system behavior over time. Remove instability, reduce friction, support signaling, and the nervous system does what it has always done when adequately supported. It adapts. That is the principle. And that principle changes trajectories.